Alrighty, so it looks like it is 1:10. Thank you everyone for joining. My name is Madeline Mathis. I'm a second year medical student at UCSF, and it's my honor on behalf of the team that planned this subgroup to welcome you today to our session on healthcare sustainability. We have a truly wonderful lineup of speakers for you today. Our goals for the session really are for you to gain an understanding of sustainability practices and healthcare waste management in the setting of both large hospitals and community health centers. And in addition, we hope that you'll leave the session with an appreciation for the global distribution of climate change burden, as well as the benefits resulting from healthcare sustainability efforts and medical waste management. So our session today is set up with 3 15-minute talks, followed by about 15 to 20 minutes for open questions and discussion. We'd ask that you put your questions in the chat, either publicly or directed towards Ben Maines. There should be an option for you to chat him, or you can just put it in publicly. And then we can record them and kind of call on you in the order that they were put in. And record any unanswered questions for follow-up after the session. And you're also welcome to chat me if you have any questions about that. So with that, I will let Dr. Jody Sherman share her slides, and I'll go ahead and introduce her. So Dr. Jody Sherman is an associate professor of anesthesiology at the Yale School of Medicine, Associate Professor of Epidemiology in Environmental Health Sciences, and faculty at the Yale Center for Climate Change and Health in the Yale School of Public Health. She is the founding director of the Yale Program on Healthcare Environmental Sustainability and the medical director of the Yale New Haven Health System Center for Sustainable Healthcare. So Dr. Sherman, I will pass it over to you. We're looking forward to your talk.
Sorry about that. I couldn't figure out where to get the controls to unmute. Well, thank you for this opportunity. And I'm just going to dive right in. So we're here asking the question, why sustainability in healthcare? Well, it's important to realize that pollution is a leading cause of morbidity and mortality, globally responsible for 9 million premature deaths annually, or 16% of all premature deaths are due to pollution. And that healthcare itself is a leading emitter of environmental pollution. That's against our mission to first do no harm. And then if we focus on reducing healthcare pollution as health professionals, we can improve the triple bottom line, which is the best care for the most patients at the least cost. And importantly, engaging health professionals around healthcare pollution, I believe, is a key linchpin or keystone for engagement for public policy and societal transformation. So let's talk about this new concept of planetary health care. We've heard about planetary health, but what about planetary health care? Planetary health care requires embracing an expanded notion of the principle to first do no harm, beyond the care of the individual patient, to include duty to protect Earth's natural systems on which intergenerational health and well-being depend. This lens acknowledges the crucial linkages between ecological health, human health, and our ability to thrive. So it's sort of a new concept to introduce this into healthcare. And so it challenges us to ask the question, what's best practice both for patients and public health? And like you all, I got interested in this during my training. It was so much fun taking care of patients once you finally hit the wards, and particularly, once I started residency, it became really clear. I am an anesthesiologist. I do practice anesthesia. And it's so clear that our materials are coming from somewhere, they're going somewhere. We use a lot of disposables, we waste a lot of drugs, we waste a lot of things. We must be causing some harm to public health. And so it's quite obvious. And so I certainly started asking the question, how could we do a better job? And there was literally no guidance information when I was in my training. And so that was what inspired me to do this research and to try and improve practice. And so with our collaboration with the Lancet Countdown on Climate Change and Health, we now know that globally healthcare is responsible for nearly 5% of global greenhouse gas emissions. Healthcare is an enormous economy, nearly 20% in the US, 10% globally. And of that 5% of emissions, about a quarter of that is coming from the US. So we're number one, but not in a good way here. And we only have 4% of the world's population. So we're, not only is it a problem globally, but the US is a leader in not doing things well. And we have the highest per capita greenhouse gas emissions in the world. And if you look specifically at the US and track it over time, we now know that US healthcare emissions are about 8.5% of our total national emissions. And this trend is rising at about 6% annually. There was a little dip that you see in 2012 as we made major progress in improving renewable sources of energy. But by and large, globally it's rising everywhere, but at an even higher rate in the United States. So, and if US healthcare were a nation itself, it would rank 13th in the world for greenhouse gas emissions. And so we associated the findings or the greenhouse gas emissions per person, per nation, with the Healthcare Access and Quality Index of the Institute of Healthcare Metrics. And what we found was quite interesting. So you want low emissions per capita in healthcare, and you want high quality, right? So that's what this index is for, access and quality. And you'll see that the best performers are from the OECD nations, particularly in Europe. And an exemplar here is France. And again, you see US as an outlier here. Not only do we have the highest per capita emissions, we do not have the best healthcare, which we know. We don't have the best health outcomes. We don't have the best access. And in fact, our emissions about 4 times that as France, even though we have not as good performance. And we also know that about 10% of our population in the US is, 11% is uninsured. And we also know that about 1/3 of healthcare services are deemed low value. And so the good news is that means that there's actually room for improvement. We can improve quality and access to care at the same time as cutting our emissions. Now, we can cut emissions by providing less care. That's not what we want to do. We want to increase access to care and increase that quality. So there's room for improvement. And so understanding where to do those improvements, we have to understand where within the health system those emissions are coming from. The greenhouse gas inventory protocol is a way of understanding or categorizing where those emissions are coming from. Scope 1 are those that are directly emitted from buildings, such as from on-site boilers or from inhaled anesthetics that are directly released to the atmosphere. Scope 2 are emissions that come from purchased electricity. And scope 3 is essentially the supply chain. So about 4/5 of the health sector emissions are coming from the supply chain. Globally, it's about 70%, we're 80% in the US. And big outliers here are medical supplies, medical devices, chemicals, and food. So these are things that we have a lot of influence over as clinicians. And the purpose of these scopes is to help us understand where the levers of action are. So as healthcare clinicians, administrators, and to a certain extent regulators, we control consumption of these resources, what their demand are and what appropriate use is or misuse. Whereas manufacturers and regulators, they control what's embedded in the stuff that we use and what goes to marketplace. So we have the ability to influence in different ways. And it's important to understand where those hotspots are. And importantly, if we look at the impact of healthcare pollution, we're causing harm. So if you add up, even though we're talking mostly about greenhouse gas emissions, there are other important emissions of concern, and particularly air pollution. Both air pollution and greenhouse gas emissions stem from consumption of fossil fuel. So this, that solution is similar. Let's switch more to renewable energy. But if you add up all the greenhouse gas and non-greenhouse gas emissions, we translated that into about 388,000 disability-adjusted life years lost annually in the US. Now, I'm sure everyone is familiar with the famous To Errors Human Report from the Institute of Medicine that was published in 1999, actually in 2000 came out as well. that found that 44 to 98,000 deaths occur annually due to preventable medical errors. This actually transformed how we deliver healthcare. We thought we were doing a good job. We thought we were doing things safely. Until this report came out, we didn't realize how big of a problem medical errors were. And so after this report came out, it completely transformed how we deliver care through this lens of patient safety, which seems natural now, but back then it wasn't. And really what the actuaries have told us is that there's about 10 years of life lost annually to these deaths. So if you multiply by 10, you see the harm is around, it's in the same order of magnitude. So pollution from healthcare is causing a similar magnitude of harm as through preventable medical errors and needs to be taken just as seriously. And so we say that pollution prevention is a new patient safety movement. And so when we think about how to improve healthcare, really all the elements they're typically presented. Also, you can talk about safety, you can talk about quality. They're all part of the same equation. Really what we're talking about is value. What's high value care? What's low value care? We want to maximize value. So the maximizing value is the best outcomes for the most people, so patients and populations, while minimizing environmental, social, and financial harm. So at the least cost, least environmental emissions, and social impact. So things like fair labor practices and making sure we're not simply exporting our pollution to some other company, that we need to account for these social impacts as well. And so there's really two general ways that we can improve healthcare delivery. One is to reduce waste. So everyone's interested in reducing waste. We know about 1/3 of healthcare is wasteful, non-value added. It's a problem everyone's interested in. The other way is to reduce the carbon intensity of the care that we deliver through how we choose which drugs we use, which devices we use, through care prevention, self-care. And so there are two different main ways of thinking about ultimately how we reduce emissions in healthcare. And so in some real take homes here that clinicians have to work to reduce the incidence and severity of disease, to decrease the amount and intensity of care required. So that is things like prevention, not over-prescribing, over-testing, not looking for answers when we don't have them, conveying realistic expectations to our patients. Resources must be optimized. And what that means is we need to be very mindful and be good resource stewards. We need to do a better job of coordinating care between providers, right? There's a lot of wasteful care, duplication of services efforts. By doing a better job of coordinating, we can reduce travel emissions, reduce unnecessary building use, reduce repetitive tests. And ultimately, health professionals should encourage change through individual practice, through influencing our organizations, and through getting involved in standards and policy. And so wherever we are, everybody has a role to play. Everybody can do something. Not everybody has to be a leader in their organization, professional society. Even people who just do practice have the opportunity for improvement. And I thank you for your time.
Thank you, Dr. Sherman. That was wonderful. We'll hold off on questions for now. I especially appreciated your call to action. Everyone can do something. And I think that reminds me of one of my favorite quotes, which is that the biggest threat to our planet is the belief that someone else will save it. Okay, with that, we'll move to Dr. Sati Tafoya. We're excited to have her speak. Dr. Sati Tafoya is the CEO of AST Consulting, which provides strategic leadership, operations, and redesign management advisory services to a number of healthcare academic and healthcare architecture and design clients across the US and in Canada. She was previously the president and CEO of Adelante Healthcare for over a decade and served as the director for clinical programs at both the Ohio and Arizona Primary Care Associations. She has served on the board of directors for numerous health centers and associations, including the board of directors of the Center for Healthcare Design after having been awarded the Healthcare Design National Changemaker Award in 2014. We are so excited to have you talk. You can take it away.
Thanks, Madeline. Will you advance the slides for me, though? Do you mind doing that for me?
Sure.
Great. So Dr. Sherman covered so much ground. I'm not going to repeat the points that she made. I think she made them beautifully. What I want to focus on is more at a grassroots level, community health centers, community clinics, group practices, the environments and ambulatory care where most of you will at least rotate through, if not practice for many decades, is an opportunity to get closer to the patients, families, and also, I think, to advocate for policy change. So I'm going to talk about that. My focus now professionally is on environment of care redesign, if you will, with an eye towards sustainability. Healthcare as an industry operates a huge footprint of square footage. And so we have the responsibility for lots of places where activity takes place. And so there's a responsibility there, and then there's a responsibility more on an individual basis with the people that we serve. So Madeline, you can go ahead. Dr. Sherman sort of told us the tough news and all of these aspects of the impact of climate change on human health, with a disproportionate share of that going to the underserved. Community health centers are in the front line of really tapping into the unmet need in communities where we've recently seen with wildfires and floods and all of the weather changes and weather patterns. There are social determinants, there are unstable housing conditions, food insecurity, transportation issues. All of these have been impacted, and the root cause, the root source, is really the effect on our planet. Next slide. We also want to talk about equity, because not all of us are going to see the same cause and effect. And in some ways, for those of us in more privileged environments, we may be blind to the true cost of climate change. But I think it's something that as providers of care, you want to be really cognizant of and get deeper into the histories of the patients and the families that you serve. They may or may not come to you sharing that perspective, but it's really important to understand where people live, where they work, how they get there, what they eat. Lifestyle and behavior change can impact all of those in a much more positive way. Part of what I want to focus on is what can you do generally, because you want to go home from this presentation and I would encourage you to adopt some things that are achievable and doable for you today, tomorrow, Monday morning. Generally, let's start talking to our patients and to our staff and our teammates, our partners. I think it's important to tap into the lots of great information that's out there. It's important to guide our vulnerable patients, especially when environmental impacts have been felt recently. It's important to talk about the effects of pollution, whether it's our air or our water quality. And then nutrition is an important aspect. Many of our patients are making lifestyle and behavior choices from a socioeconomic lens, but some of the healthier for the planet choices are also the most cost-effective for our patients. Next slide. If you're interacting with those who have no homes, I think it's, again, an area for advocacy for healthcare providers, really thinking about shelter in a different way. When we have buildings that are public or even private that are empty most of the time, how do we create safe spaces for the people that are unhoused and tap into an upstream methodology for reducing the burden of disease and the complexity of issues that come out of homelessness. Again, we're dealing with these things not once in 100 years, but I think annually, if not seasonally, we're seeing the effects of the climate change impacts in almost every community now in the country. Next slide. So from a community health standpoint, I think there are 5 areas to go back and potentially become involved in, if not to ask questions around. Does your leadership have a vision around climate change? Do you have an operational approach towards sustainability? What is your organization's mission around advocating for improved practices? Are you aware of the evidence-based and sustainable strategies that include, design of the physical plant or renovation where has a return on investment that makes the long-term occupancy of a building much more affordable, even if you have to make an investment on the front end? Should we be retrofitting our places where we deliver care or not? And then where can you find funding to do this kind of redesign? Next slide. So you have 3 opportunities. One is mitigation, the other is to develop a resilience plan. And 3 is you're all leaders. You can't be a healthcare provider without being in the leadership role of a team. You don't have to have a special title to have your beliefs and values mirrored in the way that you behave professionally and in the way that you advocate personally and publicly. I think from a mitigation standpoint, again, Dr. Sherman outlined lots of different things that we could be doing. A resilience plan is important, I think, for continuity, but also to be thinking about, the whole lifetime in a building, in a practice, in a system. We often do things in the moment, and part of the training is to respond to emergencies in a crisis. But I would say let's take more of the public health approach by creating a preparation plan and then really being in it for the long game. How do we sustain our environments and our communities for decades to come? And then leadership. You've got an opportunity with your purchasing power, with policies, and with practice to make different decisions and choices every single day, and to walk the walk, I would say. Next slide. There are initiatives like the LEAD model. There are lots of new health systems being designed and expanded and created. Buildings are being built. So I would say, if you're a part of that process, make sure that some of the checklist of items to actually green your buildings is on the table. These things might add, 3% or so to the front end costs of a building, but the return on that investment is often there within 2 to 3 years, and it decreases the cost of maintenance and the overall impact of a building for the life of the building, which could be 50 years or more. Borrowing from biophilia, bringing nature in, is always a good idea, but it happens to be more sustainable as well. And then creating a gathering place so that your building isn't just within office hours, 8 to 5 type of structure, that it's really used to its full potential to serve the community 24/7, 365. Next slide. There are things that you can do, specific things like purchasing carbon offsets or actually power from sustainable sources. They're much more affordable than they were in the past. And then creating systems like battery storage for electricity, which you can also purchase at a discount. For not-for-profit health systems, this is tough to think about more than just the current fiscal year in play, but this requires long-term financial sustainability planning for 3 to 5 years or more, because that return, again, it may not be seen in year one, but once you look at what those costs are over the long term, it really makes sense for your system. We've talked a lot this year during the pandemic about having proper air handling and exchange. But I think, it was a bit of a knee jerk. And for a lot of health systems, they sort of went to the nuclear option of having this air exchange constantly, and the amount of power that it takes to do that. When you look at, the utility of it is really, it's a mismatch. So if we have a patient that, we suspect being COVID positive or having some other communicable respiratory disease that we need to turn on the air exchange, we do that, but we don't need to do that all day long, every hour, because, there's a potential cost savings of up to 90% for not doing that in an empirical way, but really doing that in a thoughtful, effective way. Same thing with lighting. I hope that all of you are really looking at the lighting in your practice environments. We know that with LEDs and lighting that can be managed from a software system that mimics circadian, rhythm supporting lighting or natural lighting is much more helpful for our focused work. It helps us with our task-oriented work, our efficiency, and even our accuracy. So lighting's really important, both from a sustainability standpoint, as well as for our physical health. Next slide. Same thing with cooling and heating. Cooling and heating is often the most inefficient use of our electricity, our high dollar utilities. Single use, Dr. Sherman covered that. Really take a critical look at what's in storage, what is supplied in your exam rooms, your treatment rooms, your procedure areas. Sometimes kits will come packed with all kinds of things that you never use. You can deconstruct or even customize those kits to make sure that unnecessary products or unused products aren't included, and that they're not thrown away. There's an opportunity to work with your group purchasing organizations. If you look at the supply costs for any health system, it's often third or fourth after salaries and benefits and occupancy. So you can make a big dent in your overall operating budget just by doing the sustainable practice. The other thing is, I've had really small clinics say, well, what can we do? We don't, we really don't fit some of these criteria. And I said, are your computers on 24/7? They're like, yes. I said, well, if you install software that puts them to sleep when they're not in use, you can save $100 or more annually. And so for a health system that has, a few hundred employees, that savings could be that full-time position that you're missing today. Next slide. These are other community-based initiatives that you can be a part of and influence both within your organization, personally, and in your community. Anytime that we promote composting, recycling, hosting local suppliers of food and other things, and bringing the community together for things like meals. There's a group that does a stone soup. If you've ever read that book as a child or with a child, it's really about everybody coming with what they have and putting it all together for the good of the whole. And so I think this is an opportunity to get involved and address climate change without it being overwhelming, to really, again, focus on the grassroots level. Next slide. I think that it's important to have goals, especially things that you can measure. Are you as an organization advocating for improved nutrition? Well, could part of that be advocating for plant-rich diets? And a strategy under that be working with your local growers to have available, fruit and vegetable boxes at a discount for staff and for patients. So that's kind of the way that you can implement some of these ideas. Next slide. There are some really wonderful organizations out there that you can join or become a part of. Intermountain Health actually developed a counseling framework for talking to patients about risks from air pollution. The Nurses Climate Challenge is actually educating nursing professionals on the impact of climate change and giving them, again, a framework with which to practice and be a professional advocate. So I encourage all of you to find a place where you belong and where you can find that support to take your beliefs into your personal life as well as your practice. Next slide. I'm a self-professed tree hugger, and I encourage you to look at where you work, where you practice, and actually think about trees and whether there's a canopy there. So much of our urban landscape, it lacks a canopy and it lacks the trees that can help with that carbon exchange that we all need and producing better air quality. So this might be an old idea. It might seem soft, but I think it's one that we could really make some lasting impacts for hundreds of years by getting more trees onto our campuses. Next slide. Again, from an infrastructure standpoint, procurement, all the stuff we order, and then transportation, our own commutes, and the fleets that our health systems use. These are the big places where carbon emissions come from. It's important to go back and really scrutinize every step in that chain and to look at areas where you can make a difference. Often they're just small changes that make a huge impact, and nobody can really tell the difference, but it takes somebody to ask the questions and to actually look at each point in the process and ask why. Next slide. We talked a little bit about transportation and then doing more sharing. Having different ways that people can come into work, really asking if people have to come into work, taking more cars off the road and having different ways to transport themselves if they've got to do that, but supporting them once they're there. So if you've got a bike program, making sure there are shower facilities. If you have a commuting program, making sure that there are incentives for those employees that are volunteering and using their own vehicles to transport coworkers. Next slide. The other thing is, walkable areas. So this building has a sidewalk all the way around the building. Anytime that you're part of a capital project, to really ask the question, we're going to pour concrete anyway. Is there a way that we can ensure that our campus is walkable and that we have sidewalks? Next slide. These are some of the other resources if you're interested, and I think Madeline and Ben will have those available for you. Thank you.
Thank you, Dr. Sati Tafoya. That was wonderful. One of the things that you highlighted, I think, was the importance of engaging leadership. And I just wanted to let our audience know as well that we'll have a roundtable with healthcare leaders from 4 to 5 today. So that's directly relevant. Thank you again for your talk. And with that, I'm going to transition to our last speaker of the day, Dr. Cassandra Teal, who is an assistant professor at New York University in the Grossman School of Medicine, the Wagner School of Public Service, and the Tandon School of Engineering. She was a 2014-2015 Fulbright Narrow Academic and Professional Excellence Fellow, where she focused on environmental footprint calculations for surgery at a center in southern India. So Dr. Teal, your work and your publications are fascinating, and we're thrilled to hear your talk today.
Great, thank you so much for having me. Yeah, so this follows on nicely with the previous two speakers. I work a lot with Dr. Sherman, so it's kind of fun to be presenting here again. I just want to get us all thinking about these clinical spaces, as a lot of my work is really looking at the nitty-gritty details of these clinical spaces. So Dr. Sherman had talked about kind of like a top-down approach, right? Looking at the broad sectors. And my research tends to focus on individual care pathways or procedures and kind of building data from that ground level up. So just to get us thinking about those clinical spaces, you know, how many of you have worked in an inpatient unit? And you can think about all the resources that you need to provide inpatient care. You may have worked in an operating room or been able to observe surgeries. There's obviously a lot of resources that go into this particular clinical space. But more than those common clinical spaces, right, we have this supply chain that was mentioned earlier. So how many of you have actually visited your hospital supply room? Not the supply closet, but the actual big supply room, usually in the basement of the building. And have any of you been further up the supply chain to see where supplies are actually manufactured? There's lots of layers to this manufacturing process. This is a custom surgical kit manufacturing facility where they're bringing in supplies from all around the world and wrapping them up and sterilizing them and sending them to our hospitals here in the US. We have, of course, reusable supplies that we're dealing with. How many of you have been to Central Sterile? I was kind of surprised here. One of the hospitals I work with had a new chief medical officer who disclosed that he had never seen a Central Sterile before becoming the CMO, which just sounded crazy to me. Like, this is such an integral part of surgeries. Sorry if you can hear the horns in the background. In New York City. How many of you have seen a laundry facility, right? We tend to rent most of our linens in healthcare, and they get shipped out to a third party where they're laundered and then sent back to us. And going further downstream, right, these single-use supplies that we're constantly using, do you know where they go? Have you seen where they end up in your building? And just how much of that garbage is piled up there, and the people who work with that garbage to get it out the door. And even further downstream from that, you know, where is this waste treated? Where does it end up? This is a medical waste incinerator in India. You know, most of our waste ends up in landfills, but those are landfills in our communities. So when we think about healthcare services, there are a lot of aspects to delivering care, and that means there's a lot of different ways that we can start reducing our environmental footprint and mitigating our climate impact. So one of the tools that I use to help provide data to clinicians and administrators is called life cycle assessment. It's basically a tool to quantify the environmental emissions of a product or process across its life cycle. So you can think of the life cycle, right, as raw material extraction. Everything has to come from somewhere. There's transportation to various manufacturing facilities where these products are made, and then they're transported to the hospitals where we use them. We might reuse some of those things, but ultimately they'll end up being disposed of, typically in a landfill, sometimes an incinerator. And life cycle assessment basically lets us outline all of these different stages of these product life cycles, and then estimate both the inputs to each of those stages and the outputs, emissions like greenhouse gases, emissions to air, water, and soil. And we can sum those up across the life cycle, and that's kind of where a carbon footprint comes from. So we're using this tool in healthcare facilities. My students and I end up observing a lot of clinical care. And then for our primary data collection, we tend to do a lot of weighing. Typically it's waste audits. We love garbage. There's no better way to see what kinds of things you're consuming or using than by actually digging through your trash and measuring it. And people get kind of excited about it, even though it sounds kind of gross. People like to see all that. So it's a good way to engage your workforce as well. This was some of my earlier work, actually with Dr. Sherman as well, but this was hysterectomies. I had done this with Dr. Noe Copley-Woods and Melissa Billick at University of Pittsburgh. And we just wanted to know, where is the footprint coming from for hysterectomies in particular? So we audited their garbage. We sorted out all of the surgical waste by type of material so we could use it in a life cycle assessment. This is the garbage from one hysterectomy. So those of you who work in clinical spaces will not be surprised by the amount of waste generated. But the waste audits really allowed us to understand a lot more about the process, right? We found a lot of AA batteries that had only been used for 2 hours. We found reusable instruments that were accidentally wrapped up in the drapes and thrown away as they were turning over the operating room. And we found a lot of unused, unopened items that, according to local policy and regulation, needs to be disposed of, even though it wasn't opened and is still sterile inside the packaging. So these were very fascinating findings, especially for me coming into this realm. I'm an engineer, and this is my first experience really in the healthcare space. And I recognize that there are plenty of opportunities to improve things without negatively impacting the quality of care. And so just a note about those unused items, this is one really easy win all the way around. This is a study out of California looking at neurosurgical department, and across their procedures, they found that their unused supplies were amounting to about $3 million a year in supply costs. So if they could somehow get rid of those unused supplies, they would save a lot of money as a department. So there's a lot of opportunity, particularly I think in this unused items space. Now, this is what a life cycle assessment result might look like. It's overwhelming. And our clinicians working on this hysterectomy project definitely weren't a huge fan of this graph. As an engineer, it's very exciting to be able to squeeze all this information in. But we were able to look at different parts of a hysterectomy, right? The energy, the reusable materials that are used, the disposal of single-use materials, and the production of single-use materials. And we were able to look at a variety of approaches to hysterectomy. That's that AVLR, it's abdominal, vaginal, laparoscopic, robotic. And then each grouping is a different type of environmental emission. So that second one, GHG, is greenhouse gases, but there are plenty of other environmental pollutants that we should be concerned about. It's just climate change is the most pressing existential crisis we face currently. So this graph is a little unpalatable, hard to get your mind around. So we kind of reanalyzed the data looking specifically at laparoscopic hysterectomy. And this is what we came away with. If you were actually going to try to reduce emissions, what were kind of the big zones that you can make an impact in? And we had surveyed a bunch of obstetricians to ask them, if you're doing a hysterectomy, what's the bare, what's the bare number of instruments that you would need to actually perform this procedure? And using their feedback, we estimated that the carbon emissions from that bare instrument set would lead to a reduction of almost half of the carbon footprint from what we had measured earlier. And so that's that 46% kind of in the middle of the slide. Right below that, you see reprocessing of SUDs, single-use devices. So this is a reuse market that's available for some products where you send single-use devices to a commercial reprocessor. They clean and sterilize them and sell them back to the hospital at a reduced cost from the original manufacturing. And that process is estimated to save about 10% of your carbon emissions. You can see anesthesia there has a really big potential to reduce carbon emissions when you're talking about this procedural level, and that's because of the greenhouse gas, the greenhouse potential of desflurane in particular. So there's different things you can work on in anesthesia. And you see recycling on the far right there, which is a really popular approach to sustainability. That will probably only save about 1% of your carbon footprint, at least for a specific surgery. So our takeaway here was really that reduce, reuse, recycle is important, but in that order. So reduce what you can. We've been using LCA in many other clinical spaces just to give each specialty area, each type of clinician something to focus on, right? Something where they have data that they can bring forward to try to address changes. So working with colleagues in interventional radiology, this was an interesting find because radiology, traditionally energy is a really big part of it, but with interventional radiology, it's kind of like a surgery. So single-use supplies also are a pretty big factor. But that heating, ventilation, air conditioning is really an energy issue and a space utilization issue, as we also heard earlier. We're looking at inpatient units. This paper is currently under review, but we've been comparing to the United Kingdom to see differences across different countries. We've been able to look at biopsies in a surgical pathology lab. So this is also work with Dr. Sherman and a whole bunch of other great colleagues. And this information just really helps these specialty areas move forward with data-driven results so they can focus their efforts on things that will actually lead to changes. We've also kind of gone outside clinical spaces to say, what are things like in a hospital kitchen? This was just looking at waste in a hospital kitchen. We actually audited garbage for one day. It was about 1.8 tons of garbage coming out of this hospital kitchen. So pretty impressive load. And if they were able to implement composting, they could save quite a bit on greenhouse gas emissions and divert a lot of waste from local landfills. So there's a lot of different options here that can make quite a difference. So what can we do? Well, healthcare is a big, complicated system. I tend to focus on these physical things like energy and materials, but it's not as simple as just saying, remove these things. You have to think systematically, right? So payment and reimbursement is a big factor on what hospitals and healthcare facilities are willing to change. The contracts that you have with your suppliers really affect things. You have to think about what technologies are available, what infrastructure is available for, say, transportation. And there's a lot of things around policy and regulation, local training and habits that can have an influence. So solutions have to be broad, and you have to find the barriers that are preventing movement in all of these different areas. As mentioned in my bio, I'd done some work in India, and this was really interesting. So we looked at cataract surgery in a really high volume, very efficient surgical center in India and compared it to the UK. And the carbon emissions were about 5% for the same procedure in the UK with the same outcomes. So this particular institution in India is a really interesting place where we learned a lot, and we're really trying to apply what we learned from this low resource setting into our high resource setting here. And so some of my colleagues in ophthalmology have been systematically trying to tackle this waste. This is work from Dr. David Palmer, who's actually got the Illinois Medical Society to enact laws that enable him and his colleagues to dispense topical drugs to their patients from the operating room. Because in other studies that I've conducted, we found substantial waste of pharmaceuticals after cataract surgery, and some of them are actually drugs that the patient would then have to buy in a pharmacy after the surgery, even though they're throwing away 99% of the bottle in the OR. So we're just trying to find pathways to make things more efficient. In this case, it was a policy shift that was required. It's been passed in Illinois and has been presented to the National American Medical Association. And this would impact emergency rooms, emergency departments, as well as operating rooms. Global engagement is important. We've been developing tools that will help surgeons around the world audit their cataract surgical services in particular. So looking at productivity, cost, and carbon, because sustainability is not just about the environment. But comparing these sites allows us to also understand the variety of medical practices globally. And by understanding that variety of medical practices, we can actually start implementing best practices, especially from low resource settings where they already know how to do things very efficiently. So in ophthalmology, we've seen some great growth at the society level. The American Academy of Ophthalmology and the American Society of Cataract and Refractive Surgeons has joined the Medical Society Consortium on Climate and Health, and they're taking steps to work with manufacturers to develop better products, more reusability of products, and they're also working with groups like the Joint Commission to try to encourage more sustainability. We also have international eye groups that are working on this too, with climate action working groups, doing some great work to try to promote sustainability as we build capacity for care across the world. And as a personal story, I recently had a baby, and unfortunately I tested positive for COVID right before I went in for labor. So I had to be in an isolation room, which was pretty appalling coming from the sustainability side of things that I'm coming from. But fortunately, the institution where I gave birth was using reusable isolation gowns. And I would just like to point out that, one, it's possible to have reusable items in clinical spaces. They are perfectly safe. And one could argue that they're even safer than single use because you have better control over your supply chain. You can better test and verify the sterility of those products. So here, these reusable isolation gowns likely reduces the footprint, right, from when compared to disposable isolation gowns that they have to buy brand new. And as we found out with the COVID PPE shortages, this allows them to have their own stock of PPE. It's theirs, they own it. Government can't come in and confiscate it. There won't be supply shortages when manufacturers shut down. So it has a dual benefit of mitigating impact, but also increasing resilience. So while labor and delivery was tough and I was sad at how much resources we needed to bring this little life onto the planet, I was very happy that at least we had a slightly smaller impact, and I'm sure many patients would appreciate that as well. So that's all I have for today. Thank you so much, and I look forward to hearing your questions.
Thank you, Dr. Teal, and thank you especially for that anecdote at the end. I think we're all excited for you and your baby, and yeah, there's no downside to reusing. So I will pass it over to Ben, who has been collecting some questions, and will either call on people, or if you prefer, we can read the questions or comments that you've sent in.
All right, great. Thank you, Madeline, and thank you to all the speakers again. Really great to have you here. We have just a couple of questions that we had prepared ahead of time that actually, I think maybe I'll save those to the end, and we'll focus on the questions from the audience first. So if I could call on Heather Whalen for the first question.
Sure, thanks, Ben. I was just curious to hear from all of the speakers. I found it a little bit challenging to engage leadership. I'm at the VA. UCSF, I think, is a bit more engaged in sustainability work, but what is for physicians, trainees, students, what are the effective strategies to reach leadership when they have so many competing priorities and they might perceive this as costing more money, at least in the short term?
Ben, you want me to take this one? Having gone to the other side and been CEO of a health system for almost 15 years, what I can tell you speaks to the C-suite are putting yourself in their shoes. So it's not just about costs, it's that return on investment. So efficiency, supply chain, all of those things that are already on the books. If you have ideas or opportunities to either save dollars, create efficiencies, create capacity, which is another thing that most health systems are always trying to do. There is more care and more need than we have workforce and capacity. And I think that's a real opportunity with some of these, this checklist of things that you can get involved in, or activities or changes that you can make. And it could be stuff, supply chain, it could be conversations with your staff. But I would pick something, start somewhere, and kind of test it, go through that PDSA cycle of, okay, I think this is achievable for me. This isn't too much effort. Here's the result from it. Let me share that with my leadership team and see where we can go from there.
Yeah, and if I can add to that, well, there are certainly opportunities to, sorry, the sun is right there. There's certainly opportunities to save money, and the C-suite is always interested when you talk ROI, return on investment, which is a term I didn't know as a med student, and you will become deeply acquainted with it. Most sustainability initiatives are cost neutral. or save money? Is it possible that some of them cost money? Sure, but it's the right thing to do. And really have to start from the mission, the why. This is the right thing to do. And not only that, but there is reputational risk involved. Well, we tend to feel good in healthcare that we're already doing good in the world. And if we're causing some harm, at least we feel good at the end of the day taking care of patients. But the reason why we do these studies is to make the case, to say we're causing harm. It's big, we know where it's coming from, and it's our duty to cause no harm. There are plenty of studies that show that there's greater staff retention and lower staff turnover costs when corporations behave responsibly. That includes healthcare organizations. And there's a groundswell of interest in this topic. So the more you talk about it, and the more you get other people to talk about it. There's a recent study that came out that literally said we just don't talk enough about it as healthcare providers. And so we need to start talking about it.
Great, thank you so much. The next question is coming from Tim Knowlton.
Hi, everybody. I'm Tim Knowlton. I'm a fourth-year med student at Tulane in New Orleans. I'll be applying to the emergency medicine MASH this year. My question is if there are any kind of nationally standardized ratings on sustainability that hospitals or specific departments have that people like me can easily ask about during residency interviews and compare these programs, when we're creating our MASH lists.
You're talking about programs or institutions or all of that. I mean, I would say that firstly, you have to ask the question. Fortunately, in the field of sustainability, in anesthesia, my specialty, we have a lot of activity. There are also in the field of ophthalmology, thanks to the work of Dr. Thiel, there's a lot of activity. There's a lot of variation, but there's a lot of interest, and it's important that you ask questions, and because that's going to show that it's important to trainees, and that's part of their decision-making process. In terms of department rank, there's nothing like that yet. In terms of hospitals, there are international frameworks that allow us to create standards, CSR, corporate social responsibility reports. Most healthcare organizations are not reporting yet. There are a handful that are, but you have to ask the question. That's where the standards are coming from. And in fact, we see mandate coming in the very near future that's going, especially with the new Office for Climate Change and Health Equity, that we're really advocating for mandated health organization reporting, which is it's gonna diffuse every aspect of care. And that's why we're trying to hit it on the regulatory front. But you have to ask the question, absolutely.
There are a couple of membership organizations that you can look at their members and get a sense of, maybe even during your interviews, how active the clinical and medical staff are. So one would be Green Healthcare, the other would be Healthcare Without Harm. I think it's important to actually ask those questions and to say, this is something that's important to me. How does your organization get involved in this, or are there opportunities for me as a resident to champion this cause?
Yeah, just mirror all of that. You can ask about their participation in these organizations. You could ask about green team structure. Is it part of the executive leadership team, or is it just all voluntary, volunteers from various clinical spaces? That'll show you a lot about their commitment to sustainability as well.
You could also ask about departmental funding support or opportunities. So for example, my own specialty, trainees are required to do QI projects as part of their responsibilities before they graduate. And there's a lot of interest in this work, fits very squarely within the quality improvement framework. So you can ask very specifically, is there research funding support or any support to do these projects?
Thank you all. That's very helpful.
Great. And then Dr. Gail Lee did have something to say.
Hi, yeah, I'm Gail Lee. I'm the Sustainability Director for UCSF and UCSF Health. And I was the Environmental Health and Safety Director for Sutter Health Hospital. And we focused on the environment of care. So somebody mentioned the environment of care as an area where we could focus on this. And to make a bigger impact, it would be great if we can influence the Joint Commission to include sustainability in the way they evaluate hospitals. It certainly can be included in their solid waste, hazardous waste reduction efforts. Right now, there's no requirement to reduce waste at all. But if the Joint Commission said this is something we should do, and they could be scored and rank on it, then that's an incentive. In addition to energy efficiency and water conservation, those are all areas that could be incorporated into the Joint Commission survey activities, and then it would send a signal that it's an important value that they have.
I was wondering if I could ask a follow-up question on that, just out of curiosity, something that I've been thinking about. So with the AHA annual survey, is that an area where we could include something like waste generation? Would that be an interesting avenue to just get more environmental information on all these different hospitals?
So I would say the answer to that, those are both great questions, great ideas, and the answer is yes. The challenge is, for our students who don't know, the Joint Commission, they're an independent group that's initially tasked with ensuring compliance with CDC regulations. So they also have developed their own performance metrics in addition. So they go around, they're the ones who do the enforcement, they do the accreditation. You have to get the accreditation from them to qualify for federal funding through CMS. And so they have a lot of influence. If they say you change something, even if it's right or wrong, organizations will do it because they want to be in compliance, get it off their list. And while well-intentioned, they're actually creating a lot of the problem because they're looking at problems in isolation and driving a lot of the shift towards single-use disposable and driving up costs, driving up waste, and they are really an important problem to address. And as Gail was saying, actually an important opportunity that, instead of being penalized for not having disposables, imagine if we were penalized for not recycling our waste as an example. Not recycling is very low value, but you get the idea. And then to follow up with Dr. Thiel was saying, absolutely. So, we envision that the AHA could oversee things like facility compliance, including waste management. We also see CMS overseeing the clinical operations and performance. So 100% yes on both of those things.
I'm going to reiterate my grassroots advocacy and getting engaged in some of those peer organizations, committees, and the like that do have influence over regulatory bodies. You're all absolutely right. Joint Commission's only one regulatory body, but there's this dynamic between infection control and environment of care that's really at odds. I think it's up to us, especially as healthcare providers, to say, it's not an either or, it's an and. We know more, we can rely on the data, we can make conscious decisions without risking the infection control policies and procedures that we know we need to abide by. But that does require you to become champions, to kind of pick your lane and what you're passionate about, and then become involved and become an influencer in those groups that then set policy. I think it's super important for us to be at the table.
Well, and now Todd Sack.
Thank you. Yeah, I have a slightly different point of view. I really admire Jody Sherman's work that points out that if you look at healthcare's greenhouse gases, only about 1/3 of it come from our hospital systems, our big hospital facilities. And yet most of the work we've talked about today has been how to work it within our hospitals. And I really think that from a management standpoint, we need to direct more attention to our clinics there and ask that our managers be required to have sustainability units in every clinic, rather than a piecemeal approach where each of us takes a topic like recycling or syringes or something, that management be required to have sustainability programs in every clinic. It does save money. That's been well documented. It also has that reputational advantage that Jody talked about. When our patients in our clinics see us going green and explaining to them how they can go green at home, we have a huge impact far beyond the walls of the hospital.
Thanks, Todd. I just want to reiterate the important point that Dr. Thiel made, that when you're inquiring about programs, understanding what the green team or sustainability group is doing, that it's not just a happy band of volunteers, merry volunteers, that there's actually investment by the healthcare organization, by the department, that they're actually investing in dedicated resources. That's really important. So we have to ask those questions.
Yeah, I agree. And I think going upstream to supply chain and purchasing, and then the influence that we have over our hundreds of thousands of patients, especially over, over a career. Someone said there are, 8 or 10 corporations worldwide that have sort of contributed to the mass 75 or 80% of the climate change effect. And they're the usual suspects. They're oil companies and manufacturing and the like. We can have those conversations, and we can talk about what kinds of choices we make as individuals, what kind of purchasing power we have, and how we behave, and how that can contribute to that long-term dent in the climate effects.
All right, I think we have time for maybe one more question or two. And Chelsea Landolin was on the next on the list.
Hi there. Yeah, I wanted to ask whether you, and this has been touched on, I think, in the overall picture with accreditation, but at the institutional level, would you advise that there be a policy of doing things like regular waste audits? Is there a recommendation you would have for us in that respect? So I think that's for Cassie, but please, anyone else.
Yeah, I think the waste audits are very valuable. The structure that, I don't know if I'd have specifics in terms of, how frequently would you want to do it? I think annually sounds like a good number. Waste audits can really tell you a lot about your sorting practices. If you're actually fulfilling obligations for the way that waste should be sorted at a minimum, right? That's just kind of are we meeting standards? But it can also give you insights into where you can improve things, reducing unused items, changing end of life pathways for, say, batteries or something like that. So waste audits can give you a lot of really interesting information, and it is very visual and engaging. So yeah, I don't know if I would mandate it just yet, but it is definitely a great way to get people engaged on this topic.
Thank you.
And if I would just add on that depending how robust your data management systems are, you can, and the C-suite is very interested in this, if you can look at the differential between what is actually procured and what is used, which is not an easy thing to do. Again, it depends on the robustness of your data system. But trust me, make friends with the people who manage the data. And you can ask, if you ask very discreet questions, you get very interesting answers. And that's another way to do audits.
Wonderful. And I think we have just time for one more quick question. Robert Gould.
Yeah, hi. I want to thank everybody for a great panel. I had one question I'd raised in the chat that I think is similar to that raised in the comment raised by Carly Hampshire. Is there anything that we could learn from other systems beyond the US, and particularly when there's important movement in our own country for single payer healthcare, Medicare for all, whether there are any lessons from systems such as the UK in being able to get a better handle on getting the efficiencies to move towards a greener healthcare system than the often divided and competitive model that we have here in the US.
Hi, Bob. Nice
Hi,
to see you. Yeah, I mean, listen, I think, you're probably all preaching to the choir here that, I think it's probably safe to say that the people in this group agree that, that universal healthcare is the way to go. That's a pretty large ship to move. If we look to the UK, which is the global exemplar, they're the 5th largest employer. They have something like over 3.2 million employees in their national health service. and they've committed to going to net zero. They've got a whole staff. They've got a chief sustainability officer, Nick Watts, the former head of the Lancet Countdown on Health and Climate Change, a lot of resource invested in this, and have the most robust global health system reporting globally and for the longest time. But one unique thing about them is that they have the Climate Act of 2008 that mandates that they nationally draw down their emissions, and that affects all their government institutions, including healthcare. And so if we look to them and see them as an exemplar and why are they getting further ahead than us, it's because they have a mandate. We don't have that in the US. Voluntary reporting is not working for us in the US. Very few healthcare organizations are doing the right thing or doing it according to science-based targets and timelines. There's a lot of interest, a lot of haphazard, but very little health systems that are properly engaged. And so that's why we were advocating for the Office of Climate Change and Health Equity to work with CMS. And while we have this window to be able to pass laws marginally, that we mandate health system reporting according to a standardized fashion, because once that happens, everything will flow from there. Obviously, we want universal health care, but what's going to happen more quickly.
Thank you.
And that brings us to 5:20. I think everyone who planned this is thrilled with the discussion that we were able to have. So thank you to everyone who asked questions, and especially thank you to our 3 wonderful speakers. I will just let everyone go with by saying that from 2:30 to 3:40, there will be again 2 concurrent sessions that you can choose from. The first is medical and community education, and the second is air pollution and wildfires. And then from 4 to 5 today, we'll have a roundtable that I mentioned earlier with healthcare leaders on climate justice at academic medical centers. And lastly, from 5 to 6, we'll have a virtual happy hour where we can continue this awesome discussion. So thank you everyone for joining. And again, thank you to our speakers.